Hope everyone's having a fantastic morning. This is Amy, your SASH training coordinator. Welcome to the SASH coordinator webinar for May. So here's our agenda for today. We're going to have a SASH update. We're then going to do a training understanding opioid use in older adults. And because of the length of the training, we're not really going to have a lot of time for other conversation, so to speak. And finally, we're going to have some time for questions. So the only real update right now is the SASH training day, which is tomorrow. So hope that you all can join us. Registration is going to start at 8:15 and the training itself starts at 9 and it's at the Fireside Inn in West Lebanon, New Hampshire. So this year we are going to have a photo booth thanks to Jen Schulmeyer and Michelle Sawyer. We're very excited about that. We're also going to have a Qigong demonstration. Kenneth is going to take us through some Qigong. So thank you for that, Kenneth. And then finally, don't forget to create your panel poster. There were some questions that have come up around this. So remember, details for creating your poster can be found in STAR. In the news section, it was in an announcement connected to the poster that you see on the screen, the flyer, I should say. And don't forget that every panel that brings a poster will be entered for a $25 gift card. And of course, we'll have all the wonderful presentations and networking and a panel on healthcare in the state of Vermont and a whole host of other things. So it's really going to be a fantastic day, and we can't wait to see all of you there. So now on to our training. So welcome to Understanding Opioid Use and Older Adults. This training will cover the terms and definitions associated with opioid use, the prevalence of the problem, risk factors to look for, screening, interventions, and prevention of opioid overdose. This training was created by SASH in partnership with the State of Vermont Department of Aging and Independent Living and the Vermont Department of Health. So as we go through the content of the training, please feel free to type your questions in the chat area. We're going to do our best to answer them. If there are questions we can't answer, we'll be sharing them with Sean Fiore, who's our nursing fellow, and then we'll share all of those answers on STAR after the training. And if any of you are in a room with more than one staff person, if you could type in the chat who else is joining you in that room so we can keep track of who's here on the training. Thank you. So as a result of this training, participants will be able to define terms associated with opioid use, understand the prevalence of the opioid problem, and identify at least one intervention. So before we get started with our training, I'd like to do a poll of all of you to see how many of you have been touched by the opioid epidemic. So you'll see a poll on your screen. Has your life or the life of someone you know been impacted by addiction to opioids? If you could just answer that. And this is obviously anonymous, so just take a few minutes to take a look at that question and answer. And we can just see how many of us have been impacted by that. So I'm going to close our poll. So of the folks on the call, we have 64% of you saying yes, you've been impacted, and 36% that say no. Opioids killed more people last year than either car accidents or gun violence. This crisis of addiction can affect anyone in any walk of life. Now I have one more poll. So how many of you have known an older adult who you work with who's been struggling with opioid use or addiction? You guys can answer that question, please. Okay, I'll give you a couple more seconds. Okay. So out of the folks on the call, 54% of you say that you know somebody who is struggling with opioid use or addiction of the participants you're working with. So whether you have worked with someone who is struggling with this or not, this is kind of why we're talking about this today. So for those of you who have, to give you more information, and those of you who have not, to kind of understand what is going on and some of the issues that we're dealing with. So In 2016, there were 101 opioid-related overdose deaths in Vermont, a rate of 18.4 deaths per 100,000 persons, and more than the national rate of 13.3 deaths per 100,000 persons. From 2013 to 2016, the number of heroin overdose deaths increased from 20 to 45. Like heroin, the trend of synthetic opioid-related deaths rose from 17 to 53 deaths during the same time period. So to start the training, first we're going to cover some basic terms and definitions associated with opioid use. Opioids are substances that are created with the opium poppy, that pretty pink flower seen on the screen, or synthetics that have similar effects. Examples of opioids are opium, morphine, heroin, oxycodone, methadone, codeine, and hydrocodone. Opioids fall into the category of psychoactive substances. Opioids have the potential to cause substance dependence that is characterized by a strong desire to take them, impaired control over your use of opioids, persistent use despite harmful consequences, increased tolerance to the drugs, and a physical withdrawal reaction when opioids are discontinued. A psychoactive substance is any drug that causes the brain to alter mood, consciousness, cognition, and behavior. Psychoactive substances often act on the pleasure center of the brain, which explains why there is a high abuse potential with these drugs. Two of these substances are opioids and benzodiazepines. Opioids are a psychoactive substance that help relieve pain. They are especially well suited for severe acute pain, such as broken bones, vehicle accidents, and trauma. They aren't ideal for long-term use or chronic pain. Benzodiazepines help relieve anxiety and insomnia. Throughout this presentation, we will inform you of words that are commonly used but have developed a negative stigma. One definition that we don't have on the screen is the definition for narcotic. The word narcotic has a negative stigma attached to it, and we suggest avoiding using this term altogether. Two other words that need to be defined are misuse and at risk. Misuse is taking more drugs than prescribed for longer than prescribed for uses other than prescribed, and sometimes using in conjunction with other drugs or alcohol and/or hoarding doses. At risk is maladaptive use that causes adverse social or functional consequences and can lead to an increased risk of harm and continued use despite the risk. You may have noticed that we didn't define the term abuse. This term also has a negative stigma associated with it, so we suggest using at risk instead of abuse. What does it mean to be dependent on a drug or medication? First, psychological adaptations. A person's body will develop adaptations to substances in their body. Their body will adapt and change to accommodate the presence of the drug, thus creating a need for it. When the drug is stopped or removed from the system, withdrawal can occur. Withdrawal is a physical and psychological reaction to abrupt cessation of the substance. Intolerance is defined as a decrease in the effect of the substance over time, which leads to the need for higher and higher doses. Let's move on to addiction. Not everyone who is dependent on a substance is addicted to a substance. Addiction can be defined as a primary chronic neurobiological disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. It is characterized by behaviors that include one or more of the following: impaired control over drug use, compulsive use, continued use despite harm, and craving. It is possible to be dependent on a drug but not addicted to it. Addiction involves all of the harmful to oneself and to others behaviors involved in obtaining and continuing substance use despite negative effects. An important point to make about dependence and addiction is that a person could, and some older adults do, become dependent on a drug, but would not meet the criteria for a substance use disorder. So we have some questions that are popping up in the chat. So what about the fentanyl patch? That is a good question, Kim. I don't know much about the fentanyl patch. And Kirsten, if you or Melissa could make a note of that as a question for Sean, and we can find out more information about that. And yeah, so Kim says she has some people using that patch. So if you guys can make a note of that, that would be great. Substance use disorder is a new nationally recognized diagnostic term that is beginning to replace older terminology. Substance use disorder, or SUD, SUD, occurs when a person's use of alcohol or another substance leads to health issues or problems at work, school, or home, and it may include harmful use, risky use, or dependence. Just to make sure that everyone understands the difference, we're going to have a little kind of poll test question for you. So let me open that one up. Okay. Addiction is all-encompassing. It is an inability to stop using a drug and meet work, social, or family obligations. Dependence is where a body becomes physically dependent on the drug and requires more of it to achieve the desired effect. Is this true or false? If you guys could answer that question on the screen for me, that would be great. So just a few more seconds. 3, 2, 1. Awesome. So I'm going to share the results here. So 82% of you said true, and that is correct. Addiction or compulsive drug use, despite harmful consequences, is characterized by an inability to stop using a drug, failure to meet work, social, or family obligations, and sometimes, depending on the drug, tolerance and withdrawal. The latter reflects physical dependence in which the body adapts to the drug, requiring more of it to achieve a certain effect, building tolerance, and eliciting drug-specific physical or mental symptoms if drug use is abruptly ceased, causing withdrawal. Physical dependence can happen with the chronic use of many drugs, including many prescription drugs, even if taken as instructed. Thus, physical dependence in and of itself does not constitute addiction, but it often accompanies addiction. This distinction can be difficult to discern, particularly with prescribed pain medication for which the need for increasing dosages can represent tolerance or a worsening underlying problem, as opposed to the beginning of a substance use disorder. And as we'll learn later, many of our participants who are taking opioids for chronic pain can fall into these categories. Okay, so let me hide the poll. Perfect. So now we'll move on to the data connected to the prevalence of the problem. Some older adults are prescribed opioids, but some are not. These are the typical ways that older adults obtain opioids. The data tells us that 48% are provider prescribed, 23% are obtained from friends or relatives, 9% are purchased, and 5% are stolen, and 15% are from other means. So what does this look like? How prevalent is the problem in older adults? About 10 million older adults, or 1 in 5, have received opioid prescriptions in 2015 to 2016, and 4 million more filled 4 or more opioid prescriptions that same year. And 3% of adults aged 65 or higher are prescribed high-dose opioids. These are primarily fentanyl and oxycodone. Of these, over 75% were prescribed for chronic back pain. 50% of those also receive concurrent benzodiazepines, and 30% also receive hypnotic sleep aids. And some of the problems with opioid use disorder in older adults is that it is typically underdetected, underreported, and undertreated. Compared to younger adults, opioid use disorder, or OUD, is much less common in older adults. However, it is on the rise, and one study found significant and alarming trends. 86% of older adults with opioid use disorder have intent to take their own lives, versus 75% of the general population with opioid use disorder. Opioid-related deaths are increasing in older adults and decreasing in younger adults. Leftover opioids are a common pathway to risky use of opioids. Of the older adults who are prescribed opioids, 90% are educated about taking the medication, but only 37% are educated about proper disposal of the meds. And of those prescribed opioids, half of them report having leftover medication. 86% of these folks keep them for, and I quote, potential later use, and only 13% return them to a pharmacy or take-back program. Many don't even know that these programs exist, and we'll share more information about these programs later in the presentation. There are some factors to consider when looking at opioids in older adults. First, there is a higher rate of opioid exposure among older adults with chronic pain, approximately 40% of older adults. Also, older adults are less likely to view their use of opioids as problematic and also less likely to seek treatment. The presence of depression and anxiety can also significantly increase the risk for opioid use problems. There are also some challenging psychosocial factors, such as the presence of older adults who are socially isolated, home-based, or live in institutional care. And in some situations, misguided cultural acceptance may also exist in the form of social or family enabling. This could look like a family member not willing to see that there is a problem or hiding the behaviors to deny the existence of an opioid disorder. Now we're going to talk about some risk factors associated with opioid use. Before we start talking about risk factors, if you could type in the chat, what are some potential risk factors for harmful use of opioids that you believe exist out there? So type what you think there may be in the chat area. What are some potential risk factors for harmful use of opioids? What are some risk factors that our participants may have? Isolation, depression, yes, thank you, Paula, exactly. Pain, anxiety, isolation, too many refills from providers, loneliness, falls, history of misuse for chronic pain, insomnia, overprescribed. These are great. Family use, yes. So a lot of these definitely. So let's talk a little bit about what some of those risk factors are. There are physical and psychosocial risk factors. The physical factors are that females are more likely to use opioids than males. However, it is the reverse with alcohol. White folks are more apt to be at risk than other ethnicities. Having chronic pain or illness can also increase the risk. Being on long-term disability, taking multiple medications, and poor perceived health are also factors. Many of these risk factors overlap with the psychosocial factors. Coping styles such as avoidance of stress or stress intolerance can lead to substance use to escape stress. This can then lead to a cycle of negative reinforcement and serve as a quick fix. Other factors are psychiatric illness, affluence, social isolation, and a loss, such as the loss of a loved one, a job, a pet, etc. One of the major risk factors is chronic pain. Due to the persistent nature of chronic pain, which is defined by the pain lasting at least 3 months in duration, usually longer in older adults, it has both physical and psychological impacts. Psychological impacts such as depression can in turn make one perceive physical pain more intensely. And chronic pain also affects up to 50% of community-dwelling older adults, and this can lead to a substance use disorder. Another major risk factor is distress intolerance. What is that? It's a perceived inability to fully experience unpleasant, aversive, or uncomfortable emotions, and is accompanied by a desperate need to escape the uncomfortable emotions. Subsequent behaviors that distress intolerance can lead to are perceived as a quick fix and perpetuate a cycle of negative reinforcement, such as more drugs, less stress, and the more drugs to keep stress at bay, and then the cycle continues over and over again. There is data that supports emotional distress as a greater risk factor for risky use of opioids than physical pain. Another challenge are the barriers to identification of the disorder and the treatment associated with it. There is an overlap of substance use disorder with other geriatric syndromes. The symptoms could mimic those associated with cognitive decline, depression, and falls. There may also be silence on the part of the older adult to disclose their use of opioids due to a fear associated with the stigma of drug use. This can include a resistance to being diagnosed with the opioid use disorder. And the health workers and other folks who sometimes support older adults may feel discomfort with just the topic of drug use and talking about it and discussing it, and may have limited time with the people they're supporting to be able to see some of these symptoms. On the screen here are potential indicators of substance use. But please remember, we're not asking you to diagnose someone with a substance use disorder. There is a lot of overlap of substance use disorder symptoms with other geriatric syndromes. So we ask that you use the indicators on this slide more as a guide than a strict directory. So as you go through these, you can see how poor nutrition, memory loss, social isolation, those are things that we may see commonly, but they won't necessarily mean that someone has a substance use disorder. So it's just things to take into consideration. Now we'll go into screening and assessing for opioids. Screening is important, and there are several options available. The goal of screening participants would be to identify individuals at risk and to refer them to a higher level of care. There are successful ways to approach assessment of suspected substance use disorders in adults. It can help to be non-confrontational rather than assertive. If you try to hone in on the substance use as a problem, people may be more likely to become defensive and shut you out. Convey an interest in their overall health and well-being. This can also help build rapport. Try to discuss their substance use in the context of an annual assessment rather than singling out the substance use. Refrain from asking leading questions such as, you don't use illicit substances, right? Or you're taking your medications as prescribed, right? Be respectful, but don't be presumptive, and try to get them to tell you the quantity and frequency of their drug use. Focus on the facts, such as the drug use and the quantity of the drugs, including what the person thinks and not on the problem. How the person thinks about this topic is just as important. There is only one screening tool for assessing opioid use in patients with pain. The SOAP, or Screener in Opioid Assessment for Patients with Pain, is a useful technical tool and should be used selectively and not universally. We suggest checking in with your agency before using it. The standard version of the SOAP has 14 questions, and the short form has 5 questions. It is very easy to administer and score. It is also a validated and evidence-based method for identifying those at risk for opioid use disorder. It can be really helpful for those adults with chronic pain challenges who are taking or being considered for opioid treatment. Now we'll move on to talking a little bit about how we prevent overdose. Most people who overdose or over-medicate are unable to self-identify signs or symptoms and call for help. This is mainly due to the powerful nature of the substances. It is important for family and friends to know the warning signs, how to administer naloxone if appropriate, and to call 911. Naloxone is a medication that can be used to prevent an overdose. We'll talk more about that in a few slides. We ask that people take medications only as prescribed. If your pain worsens, that they discuss it with their healthcare provider. We also suggest not taking opioids with alcohol or other substances. This includes prescribed sleeping pills. It helps to know the signs of overdose or overmedication, not just for you and your participants, but also your loved one and family and other caregivers you may come into contact with. On the screen here are some signs of overdose and overmedication. Some folks may be experiencing an overdose and some may be overmedicated. Whatever it may be, both can be serious and should be treated accordingly. Here's an emergency response process for opioid overdose, which involves administering nasal naloxone. Not all sites or agencies have naloxone, but patients who are prescribed an opioid can also request a prescription for naloxone. This infographic is from harmreduction.org. You may want to print them out and have them available in cases of emergency. The steps are 1, try to wake the person up. 2, call 911. 3, administer nasal naloxone. 4, check for breathing. And 5, stay with the person. Naloxone is available through the state of Vermont. If you are interested in getting naloxone, you can contact Stephanie Bush, the Injury Prevention Manager with the Division of Emergency Preparedness with the Vermont Department of Health. Contact information for Stephanie can be found in your handout. Everyone has different histories with medications and handles pain differently. All patients should have individualized discussions with their primary care that incorporates their personal needs, experiences, and risks. Prescribers should now be performing risk evaluations as part of new comprehensive prescribing laws and should come up with a plan for terminating opioids at the time of initial prescription. The bottom line is the risk isn't being discussed. We should encourage our participants to ask about it. There are other pain relieving options, including acetaminophen, ibuprofen, psychological approaches such as cognitive behavioral therapy, exercise therapy, acupuncture, massage, antidepressants, and a whole host of other things. Be sure to ask about duration, how long the therapy should continue, as well as the strength of the dose that's needed to manage the pain. Confirm that it will be enough to help alleviate pain, but not to excess. Again, we want to confirm the exit strategy for safely stopping the treatment. The 3 questions on the screen are from the Vermont Department of Health website. We suggest encouraging participants to ask their healthcare provider when they're discussing opioid treatment. These 3 questions are, what's my risk of addiction? Are there alternatives I should try first? And what's the minimum dosage I need? So in the chat, it says naloxone is auto-prescribed at the ER when opioids are prescribed at the ER. That's great to know. Thank you, Jody. So now let's talk about the storage and disposal of opioids. Prescription and over-the-counter medications are commonplace in households, and even small quantities can be dangerous when misused or in the wrong hands. This issue impacts those trying to reduce substance misuse, suicide risk, and accidental poisonings. For all populations, if medication is stored safely, an overdose can be prevented and misuse of medication can be avoided. So think about the answers to the following questions for yourself. Do you live with or frequently have children or youth at your home? Do you have friends, relatives, caregivers, or home workers who visit your home? Where do you currently keep your medications? How many medication bottles do you have and how big are they? How do you dispose of outdated or unused medication? It's important to think about how you store medications in your home and who has access, and how your participants store medication in their home and who has access to their medications. As mentioned previously, people can obtain opioids in different ways. And we just discovered that for some of us, how we store our medications could be problematic for those who have access. Therefore, storage and disposal of opioids is an important issue and one that should be discussed with opioid users. We suggest 1, storing unused medication in a locked box or cabinet. This keeps the medication under the control of the user. 2, there are several police stations and pharmacies that accept unused medications in Vermont. For a complete list, check your handout. We have a whole list of them, and they're also on the the Health Vermont website. 3rd, bring them to the biannual Take Back Day. Information on that can also be found in your handout, and it's takebackday.dea.gov. And then finally, there's also a mail-in option. The link can also be found in your handout and is also on the Health Vermont website. The envelope from the mail-in option can be sent to you and it's free, but you just have to pay for the postage to send it back. So Kim wrote, in the Northeast, the Recovery Center will give out naloxone to participants and staff as well as training. Sometimes there's a cost to getting naloxone filled at the pharmacy. Yeah, there are trainings throughout the state. And if you contact Stephanie, the information that's in your handout, she can give you more information and training and all that. She's a really great resource for us. Thank you, Kim. So what can you do to help the older adults you work with who are experiencing substance use disorders? So we're going to talk about some interventions. Some useful and common interventions are motivational interviewing. For those of you who are SASH staff on the call, which is the majority, we have a training in Relias that provides a basic introduction to MI. And then there's also in-person trainings that occur throughout the year, and you can find those listed in the SASH calendar. The SBIRT, or Screening, Brief Intervention, and Referral to Treatment, we'll talk about in a little bit. Supporting the recovery of the older adult. Work with them where they're at and support their goals. SASH staff may want to work with the participant to create a healthy living plan goal around this health concern. Overdose prevention, which we'll also talk about more in a few slides, and education on the awareness of opioids and the storage and disposal of these drugs. What is motivational interviewing? It is a technique for inspiring intrinsic motivation to change behavior and resolve uncertainty. One of the basic tenets of MI is OARS, which involves open-ended questions, affirmations, reflective listening, and summarizing. The goal of MI is to explore and discuss the person's reasons for and against change. MI stresses the importance of meeting people where they're at and working with them at whatever place they are in their recovery process. In a study of 30 high-risk older adults who were using opioids for chronic pain and were at high risk for opioid use disorder, it was found that motivational interviewing was impactful. Their risk level significantly dropped. They had an enhanced ability and confidence in medication management, and they even showed some minor but positive impacts on their levels of pain, depression, and anxiety. In practicing MI, it's important to be individual or person-centered and have a respectful tone. As we mentioned in the earlier slide, meet them where they're at and reserve judgment of their thoughts or behaviors. SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. SBIRT is an evidence-based practice used to identify, reduce, and prevent risky use and dependence on alcohol and illicit drugs. What would that look like? Well, this is an example of an intervention that would follow a brief screening or identification of someone at risk. 1, build rapport, then raise the subject of their drug use. 2, extract the pros and cons from them on using drugs. 3, give feedback, ask permission, give information, and elicit a response. 4, assess the readiness from them and create a plan around their change. And then 5, a prescription for change. So summarize with a written plan, refer them to the appropriate care, or provide information. Support the recovery of the folks we work with who may be wanting to quit their use of opioids is an important aspect of the work. There are many ways we can support their recovery. First, recognize there are many pathways, no one right way. This is also in line with being person-centered and meeting them where they're at. 2, support their choices, whether it be medication-assisted, counseling, some other form of assistance, whatever it may be. Provide education to them that addiction is a chronic illness, not a character flaw. 3rd, support a holistic approach. Help them address quality of life issues, barriers to good health, and other elements of them living their best life. Fourth, promote engagement with their support networks, their family, friends, support groups, community groups. There are many groups of people who want to help them succeed. And then finally, be trauma informed. Many use opioids and other substances as a result of having experienced traumatic events in their past. So be aware of the impact these events have had on their life and continue to have had on their lives. And for those of you attending the SASH training tomorrow, we will have a conversation about ACE scores, and you'll learn a little bit more about the impact of trauma. There are also alternative ways to relieve pain that don't involve medications. Here are just a few. One, physical therapy. In some instances, a physical therapist may be able to create a program that can help improve physical abilities and decrease pain. The use of whirlpools, ultrasound, and deep muscle massages has also been known to show relief. Acupuncture. A substantial body of evidence has shown that acupuncture can provide relief for chronic pain. Acupuncture is a process where thin needles are inserted at different places in your skin to disrupt the flow of pain signals. Stress reduction techniques. Some stress reduction methods are yoga, guided imagery, hypnosis, relaxation therapy, and biofeedback. Chronic pain management. The Vermont Department of Health and the Blueprint for Health also offer free classes all across Vermont on chronic pain. The class provides information about how to manage the pain while improving health. To find more information out about this, you can check the classes on myhealthyvt.org. If you guys can type in the chat, what are some other alternative methods of relieving chronic pain that you are aware of, or maybe some classes that you have seen that your participants have attended, or maybe some of the things that your participants are actually participating in that have been shown to be helpful. So what are some other alternative ways of relieving chronic pain that you guys have come across? If you could type them in the chat, that would be great. Meditation. Thank you, Bonnie. Yeah, meditation can be really helpful. Tai Chi, and we know a lot of our sites offer Tai Chi classes. Massage and exercise, yes. Breathing exercises, Qigong, perfect. Swimming pool therapy, that sounds like something I want to participate in too. Shamanism, yeah, there's a whole host of alternative methods for pain, and a lot of people may go to medication first. But as SASH staff, this may be something that we can offer in terms of our programming. Hypnosis, laughter, yes, have laughter, exactly. Pain clinics. So as you're thinking about some of this stuff and how we can help our participants around the use of opioids, maybe offering some of these things as programming could be a way to do that. Thank you all for your suggestions. Continuing to be social, yes, music, exactly, getting out there, all of these things are great. In the state of Vermont, there are many treatment resources available. So first, 211. 211 offers support or service referrals across the state. There's also the crisis line. If you text the letters VT to 741-741, people can get immediate support around issues that they're having. The Vermont Alcohol and Drug Abuse Programs, or ADAP, can also provide helpful information. If they call 802-651-1550, this information is also in your handout. And ask who is the prevention consultant in their area. They'll be connected to someone directly in their neighborhoods. Medication-assisted treatment, or MAT providers. There are several providers all over the state, including several in Chittenden County alone. So the Care Alliance for Opioid Addiction is one of those teams of health professionals. It's called the Spokes. And then there's the treatment centers that are called the hubs. And they provide medication-assisted treatment like methadone, buprenorphine, or Vivitrol to Vermonters addicted to prescription opioids or heroin. And then MAT also has an app, and it's free and available through the App Store. It's called MAT-X, so M-A-T and the letter X. This tool enables the user to find the nearest MAT provider. Recovery centers are also available. They are welcoming, safe, and supportive environments for those interested in recovery. They offer peer supports, substance-free recreation activities, volunteer opportunities, and community education and recovery support services such as NA or AA. There's also the Vermont Substance Abuse Treatment and Recovery Directory. This is a free online resource that has information for services across the state. And there's going to be some pictures of those in the next few slides. So here is an image of the Vermont Substance Abuse Treatment and Recovery Directory. It shows the location and services being offered in counties throughout Vermont. And this is what the inside of the directory looks like. This is a list of the different counties, treatment centers, and contact information. The Department of Health is also in the process of publishing a brochure entitled Aging and Medications, What You Should Know. And this is going to be coming out later this year. So this directory can be found online, and the brochure from the Department of Health, once that is published, we will have access to it and share it with all of you. I know I talked to Charlie Gurney yesterday at the Blueprint Conference, and he is working on it. So we hope this presentation's provided a good background for you in opioid use and the challenges facing older adults. In order to spread this information even wider, the grant that we received to create this training also provides the resources for those who work with older adults throughout the state to provide a training to participants. So we have provided a few options to make this process as easy as possible. So first, there's been a trainer's guide that was created, which outlines the training for participants. And included in this guide are two options. The first option is to provide the training to participants using a recorded video. So we created PowerPoint slides, and I made a recording of those that you just need to play for participants. And the trainer guide will show you exactly how to play this training for them, and then stop it at various times for conversation. It's been uploaded to YouTube, which means that you have easy access to it. And the guide outlines for you as a facilitator how to run the activities, when to stop it, and what questions to ask. You can also provide the training yourself if you'd like, using the PowerPoint slides, and there's a script that goes along with it, so you'll know exactly what to say. The trainer's guide also includes options for handouts for your participants. So at the back, I've created the handouts that you can give to them if you want to give them just the PowerPoint slides or just the resources and some other information. So you can choose whatever handouts you want to provide to them. They include basic info, resources, and slides. And finally, we need to collect the data on the number of people that we are providing this training to. So there's a link for a JotForm survey that's also included in the trainer's guide. All of this information you can also find in STAR. It is on the Substance Abuse Resources page, which is under the Shared Resources tab. So the materials that I listed on the previous slide can be found exactly in this section. All of this information will also be linked to the SASH coordinator call information, which we share after every call, under the training tab on the monthly webinars page. So is there any questions around any of the training content so far, or any of the things that we're asking you to do in terms of providing this to participants? I can tell you that the training itself, the video I want to say is like maybe 20, 25 minutes. So you can play it, and then there's conversations to have throughout it. So we guess that the training may take no longer than 30, 40 minutes. It could take up to an hour if you have a chatty bunch of folks that you're providing the training to. And it is, some of it is the content of what we've discussed today, but then there's also additional different content for them in terms of things that they can do to help themselves and help other people they know who may be struggling with this. So we've geared it particularly towards participants. So is there any questions around that? I haven't seen anything pop up in the chat, but I want to check and make sure. And at any point in time, if you guys do have any questions about the content of the training or delivering the training to participants, you can feel free to contact Melissa or I. We are available to provide any answers. And there hasn't really, we've had one question that came up about fentanyl, but there hasn't been any other questions that I couldn't answer. So if there are any that do come up from participants that you're like, I don't know that, but I'll get the answers back, please contact us, and we can be sure to share those with Sean Fiore, our nurse fellow, who can get back to us if they're more kind of technical medical questions that we can't answer. Our goal really is to provide as much support and awareness and information that we can around this topic. Then we have a bunch of references that are also available online. So if there's no other questions, we ended a lot earlier than I thought. So in June, we're going to have a call around some SASH updates and some things that are going on with SASH for folks. And then in July, we will have a training from Pride Vermont with Skylar and Taylor, which should be a really fantastic call. We're all looking forward to that. So if there's no other questions at this point, I guess we will end the call a little early. Unless there's any updates or any information that people want to share, do let me know. And we look forward to seeing all of you tomorrow, bright and early. So have a great rest of your day, and we'll talk to all of you soon. Thank you.